We're looking at the examination of the wrist. Here we're comparing the two sides and looking at full active movement into extension of both wrists, comparing the normal and abnormal side, moving into flexion, where the wrists are raised, the elbows are lowered, so we get to the extreme of movement. We then move to a hand table. We examine across the table in a position of comfort, comparing the two wrists and hands, looking for any signs of deformity, malrotation of the fingers, misalignment. We then ask the patient to duplicate our movements, firstly moving to position of full active extension, moving from there to flexion, then to ulnar deviation, and finally moving to full active radial deviation. We then move to palpation of the prominent bony landmarks of the wrist. The most immediately prominent is the head of the ulna. We can then palpate the ulnar styloid process, the extensor carpi ulnaris tendon alongside it. We then move dorsally across the wrist, feeling the radial margin, looking for the radial styloid process, which should be quite readily palpable, and then moving across to Lister's tubercle on the distal radius. We then move directly downward from that into the radiocarpal joint space and the scapholunate space. We then ask James to cock the thumb backwards so we can examine the anatomical snuff box. We look for swelling and then palpate over the radial styloid onto the scaphoid, looking for any tenderness in that area suggestive of a scaphoid fracture. We then move to the volar or palmar surface of the wrist, palpating initially at the base of the first metacarpal for the trapezium, moving to the ulnar side to palpate the pisiform and triquetrum. We then assess passive wrist extension, flexion, ulnar deviation and radial deviation for any laxity or reproduction of pain. We palpate along the long thumb tendons, looking for any swelling, crepitus, or other abnormality. We then perform Watson's test, looking for a scapholunate instability, so palpating over the pole of the scaphoid with the thumb, the fingers placed over the scapholunate space, moving the wrist then into ulnar and radial deviation, looking for the sensation of a click, instability or reproduction of pain. The next special test is Finkelstein's test to assess for de Quervain's tenosynovitis. So we ask the patient to grasp the thumb and then move the wrist into ulnar deviation, palpate along the long thumb tendons looking for swelling, crepitus and reproduction of pain, and also looking for reproduction of discomfort with movement into ulnar and radial deviation. We then move to examination of the triangular fibrocartilage. Firstly, the press test, where James aims to lift up out of the chair, pressing down on the wrist, which should reproduce symptoms. We palpate over the distal radio-ulnar joint, looking for any instability or pain, then moving distally to the area of the triangular fibrocartilage. We then compress, pushing the wrist into extension and ulnar deviation. We then assess for signs of carpal tunnel syndrome. Firstly, Tinel's test, percussing over the carpal tunnel. We then move to Phelan's test, where we compress the area of the carpal tunnel, moving the wrist into full flexion, sustaining that position to see if symptoms are reproduced. We then assess the movements of the thumb, looking for a full range of movement into opposition and abduction. We then go on to palpate the base of the first metacarpal, moving on to the carpometacarpal joint and then to the first metacarpophalangeal joint. We assess the first dorsal interosseous muscle, looking for any wasting or abnormality of contour. We then go on to assess the range of movement, flexion and extension at the first metacarpophalangeal joint, and then move to assess the stability of that joint, firstly with antero-posterior movements, and then moving to specifically test the integrity of the ulnar collateral ligament, bracing the first metacarpal and then applying a stress across the ligament. We assess the first interphalangeal joint. James has quite a hypermobile IP joint at the thumb. We then move on to examination of the remaining metacarpophalangeal joints, again looking for rotation or restriction of movement, palpating over the joints for any signs of instability, thickening or synovitis, moving distally along the phalanges to the proximal interphalangeal joints. Again, we look for signs of synovitis with swelling and tenderness at both proximal and distal interphalangeal joints. Look for instability into hyperextension, a full range of flexion, moving to the palmar surface, palpating along the flexor tendons and flexor pulley areas, looking for swelling or discomfort.